All right, guys, we're going to do GI problems. This starts in chapter 40. It also goes into chapter 41. So chapter 40 begins on 886, so you can go ahead and get your book out. Just, we've completed endocrine, and so these are some good questions that you could stop and ask yourself, see how your studying for endocrine is going. Okay, so the different things that we have to cover are obesity, malnutrition, GERD, hiatal hernia, and peptic ulcer disease. We're going to cover these in different ways. Obesity and malnutrition are actually going to be only explain everything's. GERD, hiatal hernia, and peptic ulcer disease, we're just going to talk about the patho and then finish the care of these particular patients in class. First of all, this chapter starts off talking about normal nutrition and talks to you about the program called Choose My Plate, talks about portion control. It talks about a nutritional therapy for a healthy lifestyle on page 887. If you flip the page to 888, it actually tells you, if you do not know how to read a label, and so it shows you how to read a nutritional label. It talks about some of the considerations for people who are, for instance, vegetarian, and what we have to consider when someone is a vegetarian, and that, culturally, our nutrition is different. When we get to page 890, it starts to talk about what we consider malnutrition, and it just reminds us that it's a deficit, an excess, or an imbalance of essential nutrients. And so it results from many things. One, inadequate intake of nutrients, but it can also result because we have impaired absorption or use. So people often, and you guys have seen this, end up malnourished, secondary due to a disease, and maybe they have inadequate nutrition because of a loss of nutrients or increased metabolic needs. Excellent example, we just talked about hyperthyroidism. And so that's kind of where malnutrition comes from. There is no single cause. What do we know? As far as age, as far as risk factors, and as far as age go, we know that the elderly is at risk. And that is obvious because they have a lack of social support, at times a lack of way to get food, a lack of means to get food. We have people who suffer from poverty, and people who suffer from poverty often suffer from malnutrition because of inadequate intake of nutrients and the wrong nutrients, because as we've talked about in class before, healthier food is more expensive. We've talked about functional health problems. These would be your individuals who are hospitalized, and their hospitalization interferes with their nutrition. History of weight loss, people who have oral or GI problems, pretty self-explanatory. Goes along with that is an inability to eat, such as we just got done talking about individuals who are taking chemotherapy or radiation therapy. People who have chronic pain, this suppresses appetite. Dementia, often forget to eat. Certain medications suppress appetite. Alcohol consumption often replaces calories that have value, and then acute illnesses or physical injuries a lot of time. What we have to realize is, why we're concerned with malnutrition. And the reason we're concerned with malnutrition is because, one, it leads to delayed healing. Someone who is malnutritioned will actually experience delayed wound healing. It also increases their risk for infection. They have a suppressed immune system. They have also decreased muscle strength. And so these are some of the issues that we experience with someone who is suffering from malnutrition. There are some great pictures on page 890 that you can look at. There is a table that outlines conditions that might increase the likelihood that someone is suffering from malnutrition. Okay, so In your text, the clinical manifestations are outlined on page 892. You guys probably are going to remember these from anatomy and physiology. The most obvious clinical ones, first of all, this can be mild to really intense signs and symptoms. Often, has to do with your skin, it's dry and scaly, your mouth is crusty, has ulcerations, your nail beds look poor, your hair lacks luster, you have possible delayed healing, as we've often talked about. If you look on page 893, there's an actual nursing assessment, and it talks about some of the objective data that you're going to see. It talks about being listless. It talks about someone who's underweight for their height. It talks about someone who looks cachectic. Talks about their eyes, respirations, cardio. So you guys can read through those. How do we actually diagnose someone? We talk to them. We talk to them about their past history. We do their physical. We ask them specifically about their diet. We want to know their dietary habits. Was the weight loss intentional, unintentional? We want to look at lab studies. Of course, CBC. We can look for anemia. You can look for electrolyte and mineral imbalances. You can also look at prealbumin. Prealbumin is generally a better indicator than albumin because of its half-life. Also transferrin. And then the anthropometric measurements. The anthropometric measurements actually measure muscle mass and fat, and so it gives us a good indication of malnutrition. If you look at page, medications, vitamins, minerals are actually on page 891. You guys can review those. And but just know that I'm not going to test you on that particular chart on 891. You can just review those. Really, when we're talking about malnutrition and we're talking about taking care of someone who has malnutrition, you're talking about enteral versus parenteral nutrition. And so just remember that you guys learned about enteral and parenteral nutrition during lab. Okay, some of the principles of enteral tube feedings. It's either delivered via NG tube, a special feeding tube, gastric tube. Just remember that we have to make sure every time we utilize it, we check placement. We just aspirate for residual. And then whatever we do aspirate, though, you do return it. And usually it's not policy, but you can check pH, and it should be less than 4. We start off with enteral tube feeds. There's usually 1 kilocalorie per milliliter, and we need to give people up that are to 1,500 mLs a day that are suffering from malnutrition to meet their requirements. You start with small volumes to avoid diarrhea, and then what you do is you gradually increase. Now, just remember that if someone does develop diarrhea, then you can actually back off and gradually increase again. Okay, so that's how you kind of avoid diarrhea. Continuous tube feeds are just that. It's continuous. You have to be really cautious with these people. Just remember their beds need to be at like a 45-degree angle. If you have to lay them flat, for instance, guys, like to, change their linen, change their position, you want to suspend the tube feed while you're doing this. And then, once you get them settled, put their head back up, resume the tube feeds. All right? If someone has what we call intermittent tube feeds or bolus, then you guys just want to remember that they should really not be active 30 to 60 minutes after their tube feed, and that their head and their bed needs to actually be elevated. The principles to avoid aspiration are extremely important. You want to make sure that you review those from lab day. And the other thing is that this is a feeding that has a high sugar content, and so because of that, it's got the potential to actually grow bacteria. And so the tube feed, the tubing that we utilize is actually changed every 24 hours. Also, you guys are following along in your book. Enteral Nutrition starts on page 897. You flip the page, 98. There's some great pictures of the different types of feeding tubes, and then there's a very nice chart on the top of page 899 that outlines the care of someone who is receiving tube feeds. And so just read through that. It talks about on the bottom of this page what position the patient should be in. It talks about decreasing the aspiration risk, and it talks about checking residuals and how you should check residuals. Okay, so it's preferred that we could have enteral nutrition for people who are suffering from malnutrition, but there are times that this is not possible. So when we cannot use the gut, then we have to move on to parenteral, which means we are using a vein. It's not the first choice because using the gut is more natural, more nutrients are absorbed, it's cheaper, and there are less potential complications. But for instance, if you guys look at the top of page 901, it talks about why certain individuals might have to have parenteral nutrition. And so parenteral nutrition is just nutrition in the vein. It's a very hypertonic fluid that goes into a central line. So TPN is total parenteral nutrition. And for instance, it has a composition of calories, of proteins, of electrolytes, trace elements, and vitamins. And it can be TPN, which is total parenteral nutrition, and it has to go through a central line, or it can be partial parenteral nutrition, which means it can be given in a peripheral IV. The difference is the concentration of glucose and how different how intense the hypertonic fluid is. So that's the difference between TPN and PPN. TPN is going, let me change this color, in a central line. Okay, central line. PPN is going in a peripheral. Okay. These particular solutions are created or mixed down in pharmacy in a sterile environment. Hospital policy will vary for dressing changes. Typically, though, IV tubing changes, again, just like enteral, are every 24 hours, and that's because of the high concentration of sugar that's in it. Okay. There are many risks involved with someone getting TPN. If you flip to page 902, it talks about the possible problems. It talks about infection, it talks about the metabolic issues, and it talks about catheter-related problems. So you guys are going to want to go through these. You're also going to want to review the worksheet from lab. Okay, so someone who's malnourished for whatever reason, a good nursing diagnosis would be imbalanced nutrition less than body requirements. So we need baseline. We need baseline labs, measurements, and a weight. We need to tell them that they need to weigh every day, same time, same scales, same clothes, empty bladder. They need to understand what their therapeutic needs are. What are their nutritional needs, their proteins, their calories. We need to make sure they understand to keep a log. We need to make sure that if they are going to be placed on supplements, they understand the supplements that they are taking. Some patients, if they would benefit from appetite stimulants, such as Megase or Marinol, then they're placed on these oral medications to increase their appetite. Some patients may actually go home with enteral feedings, and there would be a significant amount of teaching. When we have imbalanced nutrition, we want to make sure we understand what the goal is. And the goal is typically that they would gain so much weight per week, or that they would not develop an infection, or that they would not have delayed wound healing, or that their wounds would actually heal. People, as we've said, with malnutrition have a risk for infection. So this is an individual we would want to explain to them, you are at risk for infection because you are malnourished, your immune system is suppressed. So we would want to make sure that they understand to watch for signs and symptoms of infection. All right, guys. Obesity starts chapter 41, and it starts on page 906 in your book. A simple definition would be just an excess of adipose tissue. If you're looking on page 907, it shows you the BMI chart. We know that a BMI of 25 to 29 is considered overweight. A BMI of over 30 is considered obesity. And if someone has a BMI greater than 40 or over 200% of their ideal body weight, this is considered what we term morbid obesity. There are times when a BMI is not accurate, especially when someone has a high muscle mass. Of these numbers, the one that is alarming is the rise of childhood obesity in the United States. And when we look at the client with obesity, we understand that if we could target childhood obesity, it would help decrease the overall issue. We know that within the United States, we are the most obese country in the world, 2/3 of the U.S. being overweight. There are many factors that play into someone developing obesity. There have been certain genes that have been identified to contribute to or be linked to someone developing obesity. Certain physiological factors certainly play into part. We know environmental factors. We are a society that's on the move. Food is much more accessible and easy to obtain. We also know that if you guys look at the table on 910 and we look at 41-4, you can just see that we're dealing with a society where portions versus yesterday and today are not nearly the same. And so a bagel 25 years ago was one that was 3 inches in diameter and only contained 140 calories compared to today 350. And the onset of sugary drinks has been huge factor in contributing to obesity. So environmental factors. We know that there are socioeconomic factors. We know those individuals that suffer from poverty have to make their dollar go a little bit further, and so they're buying packaged foods that are less healthy as compared to fresh foods, and we've talked about this in class before. And then, there are psychosocial factors. People use food for many different reasons, as comfort, as a sort of reward, and so it makes this contributes to obesity also. When we look at obesity, though, we know that the lack of physical exercise that we're getting today is the single biggest modifiable risk factor. Why treat obesity? We've actually been studying this in class. We've talked about the many different disease processes that are intensified by obesity. And so it's outlined on page 9, 10, and 11. It leads to cardiovascular issues, diabetes, especially diabetes type 2, which we're getting ready to talk about, GI and liver problems, respiratory problems, sleep apnea is huge, musculoskeletal problems, increasing the incidence of osteoarthritis on the weight-bearing joints, cancer we just talked about, flipping the page, metabolic syndrome, and then psychosocial issues. So this is why it needs to be treated. When we're looking at treating obesity, first we need to understand that 1 pound is comprised of 3,500 kilocalories. And so in order to lose a pound, that means we would need to decrease or have a negative base of 3,500 kilocalories. So for instance, decrease our intake or have a deficit of 500 calories per day for 7 days and we could lose a pound. So it is recommended that we don't do fads, that we just essentially lose 1 to 2 pounds a week and target goal as a 10% weight reduction in 6 months. And it is encouraged that we do this with a combination of physical activity. We've talked about physical activity before and what that constitutes. A diet that is deficient, at least 5 to 1,000 calories per day. Certainly behavior modification, and if needed, pharmacology. And we'll talk about the meds that could possibly be used as appetite suppressants. Knowing that surgery, which we know is gastric bypass, is the last option. once a diagnosis of obesity is made, nursing assessment-wise, we just want to, assess the patient's medical history and surgical history for anything that would be alarming or interfere with potential weight loss. And so there's a good table on page 912, table 41-5, nursing assessment, important questions that should be asked. Planning, we would want the goals to be that they would modify their eating patterns, that they would get regular physical activity, that they would achieve and maintain the weight loss to a specified level, and that they would minimize or prevent health problems that are actually related to obesity. When we use meds, drug therapy actually starts on page 915. We have drugs that we call appetite suppressing drugs. You guys probably have heard of these. We have amphetamines versus non-amphetamines. Amphetamines actually are not approved in the United States anymore because of their high potential for abuse. Non-amphetamines are listed in your book. They still, I want you to understand, do have potential for abuse, okay? And that really they shouldn't be used for more than 3 months, okay? An example, I don't like that color. Let's try this again. An example of a non-amphetamine would be the phentermine, okay? So that's a non-amphetamine that can be used. Just know that this particular drug, for instance, causes increased heart rate, can cause palpitations, restlessness, dizziness, insomnia. So you would want to do a good history on a patient before they were prescribed these particular drugs. Then if you look at the next one, the actual Morandia is actually off the market in the United States, so just cross through it, okay? Then we get into the Xenocol, and the Xenocol actually blocks fat breakdown and absorption, and because of that, this individual can suffer from what we call stool leakage, okay? It's considered a nutrient absorption blocking drug, and that's Xenocol. If you continue to go down that page, we won't test on these. There's a couple of other classes. One of them is the serotonin agonist, and it actually decreases appetite by making the patient feel like they are full, gives them a sense of fullness.